So we are moving to the next session, which is a very interesting topic, squamous cell anal cancer, and we are very honored and very happy to have again Professor Glynne Jones, who is an expert in this field, to present us personalized and standard treatment of squamous cell anal cancer 20 years after the Negro treatment.
Well, once again, thank you very much for inviting me. Thank you for inviting me to talk about something I really do like, which is anal cancer. So these are my two heroes, Norman Nigro, and someone I think has been sort of under-recognized, Roger James, who was a radiation oncologist in the UK, who sadly died around Christmas. And I think Roger, actually in the UK certainly, was instrumental in radiotherapy being used in rectal cancer and anal cancer. So it's usually a localized disease, metastatic disease at diagnosis is only about 5%. Most patients respond, but there are a few that don't. So the idea is to get the best out of your initial chemoradiotherapy, because then you get the best outcomes. And so we need slightly better treatment options, and I'll go through what the standard and others. So, I mean, Norman Nigro was really a triumph. The gossip is that his auntie had anal cancer, and he knew that just the surgical outcomes were not very good, so he persuaded the radiation oncologist to deliver some radiotherapy, a low dose, only 30 gray of radiotherapy, which is about half you'd expect to cure a solid tumour, a bit of 5-FU and mitomycin. Originally they used a drug called porphyrimycin. And his results were spectacular, and that they had a lot of patients who had a complete clinical response, and it was a bit like sort of habrogama. They operated on these patients and they didn't find any disease. So then Roger James was instrumental in the Act 1 trial in the UK, which showed an enormous difference between radiotherapy alone and chemoradiotherapy using 5-FU and mitomycin. And that's the local recurrence with a hazard ratio of 0.46 for the combination of chemotherapy and radiotherapy. So all these trials to date have kind of shown us that the standard of care is still 5-FU, or capecitabine nowadays, and mitomycin, which Nigro, the first man to do this, that's what he did. So we haven't moved on a great deal in 30, 40 years. I think there's a reasonable agreement on whether you use capecitabine or what the doses of fluoropyrimidine, but there's still not too much sort of consensus about whether you use 1 dose of mitomycin, 2 doses of mitomycin, and there's no real standard of care for radiotherapy. Hence, in the UK, we have a trial called Plato. Actually, I know I'm in Greece, but Plato's not, it's too mystical for me, Plato. He didn't have the cure. I'm an Aristotle man, which is why we have a trial called Aristotle in the UK. Because Aristotle was curious about everything. Plato wanted everything to fit with his ideas. And the other thing, Plato wasn't interested in medicine. He was not interested in medicine. So, anyway, that's by the by. So, this is our Act 2 trial that we randomized. It had a 2x2 factorial design, mitomycin C5-FU, cisplat 5-FU, and some maintenance afterwards. And as you can see, the response rates were the same, 90% at sort of 6 months, and so the trial did not show that cisplatin was any better. One of the things that we did in this trial, which I think is quite interesting, we mandated 3 separate time points where you had to assess the complete clinical response, which had never been done before. I have to say I was instrumental partly in sort of saying, actually we won't go there. But, so we have 3 time points, one at 11 weeks, one at 18 weeks, and one at 6 months. And as you can see, the complete clinical response rate increased from 64% through 80% and 85% at the third assessment. And a lot of patients who were not in complete response at the first assessment eventually became into a complete clinical response. And it was an ideal surrogate endpoint in a way, because at the 5-year overall survival is very high if you are in complete clinical response at 6 months, and if you're not, you only have an overall survival of 50%. So, but that doesn't really fit. When I trained in radiotherapy, we had 3 hours of radiotherapy, radiobiology. There are only 3. Now there are 5, but that does not fit. Now, that observation that you complete the clinical response slowly over 6 months without doing anything else does not fit with any of those R's. So you have to say, you have to invent something else, which is probably reinvigoration of your immune defences. And the fact that it is a virally induced trial in the majority of people with HPV probably reflects that. Anyway, when we look at all those 4 factorial entities, the progression-free survival is almost exactly the same, 69, 69, 70. And you can see there's no benefit from any maintenance treatment there in terms of additional 5-FU cisplatin. And in fact, if you look at the forest plot, you rarely see a forest plot with all those boxes so close in overlying unity. So I really don't think there's any advantage in giving 5-FU cisplatin after chemoradiotherapy. In terms of colostomy-free survival, we found no difference either, varying between 65 and 68% at 5 years. Overall survival, also no difference in there. But we did obviously see some difference depending on your T stage. So T1, T2 tumours did a lot better than T3, T4 tumours. And that's, that's been influential in some of the ways we've been thinking about things. So one of the things I'd like to point out from the trial we did, that we did find that the compliance, we gave 5-FU days 1 to 5 and 29 to 33, and the compliance to that second dose of 5-FU made a big difference to whether you actually had control of your disease. So it is very important that you get that second dose of 5-FU in, and I think it's beholden on us radiotherapists to keep a careful eye during the patient, during the treatment, to get that second dose in. So, what about capecitabine? Well, we did a trial way back about 10 years ago where we integrated 825 mg per meter squared on radiation days, and interestingly, just about everybody else has used that same dose over the subsequent time. And this is data from recently in the Red Journal from Goodman, showing that actually there's certainly no difference, and if anything, mitomycin capecitabine is slightly better. We did an audit in the UK via the Royal College of Radiologists, looking at IMRT with capecitabine and IMRT with 5-FU. So we just audited what people were doing in the UK, and what we found was that there was less hematological toxicity, slightly more diarrhea, grade 3 diarrhea, and slightly more pain. But actually, when you looked at this, it was probably better tolerated to use the capecitabine, and better compliance to full doses of the chemotherapy, and there were less interruptions to radiotherapy. So in the UK currently, most of us are using capecitabine and mitomycin as the platform. So it's probably a standard, mitomycin, capecitabine. Cisplatin's not better. You could use cisplatin, but it's got a bit more toxicity, I think. Maintenance chemotherapy, no benefit. Induction, the other trials, the Accord trial and the American RTOG trial did not show that induction chemotherapy prior to chemoradiotherapy did anything either. Compliance is extremely important, and again, we probably need a 6th R in there. So, how do we go forward? Well, as I said, there is no standard dose for radiotherapy. So the UK, our standard was, according to that trial, 50.4, which is quite a low dose. Australia actually is not on here, which uses about sort of 58 to 60 gray, and lots of other different countries use higher doses of radiotherapy. So we currently have this trial Plato, which takes patients with T3-4 tumours, the big ones on the right of that slide, where we're going to be randomising as a pilot to start with, and then a phase 2, seeing if we can dose escalate the radiotherapy and whether we can achieve better local control by dose escalating the radiotherapy. In the middle is the T1, T2s, the small ones there, where actually 50.4 gray is probably more than you need, and so there is a randomization between a dose de-escalation down to 41.4 gray. So I think that the thing here is that There are 5 different doses here. We know within a fairly narrow range what the ideal dose should be, so we're kind of tinkering a little bit with that. But it does mean we're going to have 5 different doses for anal cancer, and that will allow us to produce prognostic groups in the future according to P16 and according to TILs and things like that, and maybe we can validate it as being predictive as well for response. So it's personalised, because in terms of clinical stage, it could be personalised in terms of P16, which is a surrogate for HPV infection, and it is interesting that I don't know what to do with patients who are P16 negative. They do rather badly, they respond less well to chemoradiotherapy, and they have in general poor outcomes, but I don't know that we have a strategy to deal with that. But certainly P16 positive patients relapse a lot less than P16 negative patients. And there is a lot of trials which show that you have much improvement in terms of local control of DFS if you are P16 positive. In terms of tumour-infiltrating lymphocytes is another prognostic factor, and there are a number of other trials which show that as well. So we have another sort of personalised prognostic factor to look at in those terms, particularly CD8 positive cells, which are influential there. And also, nowadays, there's a bit of pharmacogenomics in terms of 5-FU toxicity that we could do to personalise this treatment. So, other sort of strategies that are being looked at. Sergei Gurdjieff in Moscow has done a phase 1 looking at paclitaxel, and so he has got a trial, a randomised phase 3 trial, which is running at the present time, aiming to randomise 300 patients, which is quite... I think for Russia it's quite enthusiastic, that. So you take capecitabine and mitomycin on one arm, that's the control arm, and the novel arm has in addition a weekly paclitaxel. And as far as I understand, they've already recruited about 1/3 of those patients. So I think watch this space, that might be quite interesting. I don't know the radiation oncologists in the room, but one of the common regimens that we use in esophageal squamous cell carcinoma is the cross regimen, weekly carbotaxel. From a radiation oncologist's point of view, personally, it's a dream. It's very easy to deliver. It's not got a lot of toxicity. Patients sail through it. And so colleagues like in Warsaw are looking at taking patients who are either very frail or have cardiac problems, and looking at, they're doing a pilot of carbotaxel, just like the CROSS trial in esophageal cancer. And I think that will be interesting to look at as well. I think in terms of the future, this has been very exciting that the checkpoint inhibitors clearly have some role, because they do express PD-1, PD-L1, these anal cancers. So if you look at the data, which is from this particular trial, it's a phase 2 trial, previously treated metastatic patients, and you had to have had at least 2 or 3 regimens. I think there are some patients there, or one patient that had 13 previous regimens. I can't even think of 13 previous regimens to give a patient with anal cancer, but that's the state. So they had a fairly modest response of about 24%. 2 of those were complete clinical responses, and some of them are sustained a bit. So these are a lot of biomarkers in terms of immune biomarkers, which I think will be useful in the future, particularly granzyme B, and I think we're going to be sort of, again, personalising in those terms a bit more in the future. And so we have a phase 1b to phase 2 trial that should start later in the year in the UK, which is a kind of pick the winner, sequentially introducing nivolumab into pembrolizumab into several cohorts, starting at the back end and progressively introducing it earlier into the chemoradiotherapy. And I think that will be interesting to see what the results are. So that's the current standard of care, 5-FU mitomycin and chemoradiotherapy. There are a lot of other things on the horizon, and we're certainly going to be personalising things in terms of the immune system in the future, I think. Thank you.
Thank you very much, Professor Glynne Jones, for the presentation. It was really excellent, and from the radiotherapy point of view, I was very impressed with all these new results. Any comments, any questions?
Please.
Dr. Glynne Jones, did you or do you stratify for HIV patients in the trials?
I think these trials you will be. I think you are entitled to treat with patients who are HIV. It's interesting that in the UK we don't have a huge amount of anal cancer with HIV, unlike in the United States. Most of those patients are treated in about 2 centres, one in Manchester and one in London. So I think I've seen one HIV patient in the last 15 years.
May I make a comment to you and a question? Of course, I see a lot of enthusiasm between radiation oncologists and medical oncologists about anal cancer, and the poor surgeons are left with the failure of this. So what's your strategy for the failure? Because still 40% of the patients will fail.
Well,
4-0.
4-0 if
or will recur. I mean, will recur. So what's the strategy?
Well, if they're T3, T4, I'm going to talk about sort of follow-up and things in a minute, so I probably won't prejudice that. But yes, there is a role for salvage surgery for sure. T1, T2s, the recurrence rates are much smaller.
Yes.
But there is a role for salvage surgery, but I don't think we have a standard follow-up policy. But I'll go into that in the next talk.
So we have to wait 6 months to have a definitive assessment of the patient and to say this is a response, this is a responder, this is a non-responder.
Well, I think it's exactly the same as in watch and wait.
Yes.
You look at the trajectory and you see whether patients are getting better and it's getting smaller. And if you have any hesitation in there, then you can stop and you can biopsy these patients and you can counsel the patient about what you do. But I think that it is very similar to watch and wait. That if you're on a good trajectory, you are likely to continue on a good trajectory. You will sometimes lose some patients on that trajectory, but I think they're few and far between.
Okay.
Can I just ask you something? With regards to the IMRT, so far and in your experience, do you believe that it has improved the results? Has it increased complete response rate? Or it's just a more optimized way of delivering radiotherapy, easier for us radiotherapists and just causing probably less side effects?
Well, I think that's a very crucial question. I think for sure it is much more tolerable to the patient giving IMRT. It is, previous treatment with big parallelopose fields was barbaric, to be honest, and now it is tolerable. I have some concerns. I do have some concerns that I have seen 2 or 3 patients who have recurred anteriorly around the urethra. And so I may not be very logical, but I give an extra margin around there now. I don't know that the patient, this is movement art or what, but I've got a sense that maybe my results are not quite as good because of IMRT.
Yeah, I agree with you. In fact, we started seeing some failures the way you described it anteriorly, and we do follow all the guidelines for contouring. So I think we should be a little bit more careful. IMRT is not a panacea, as we would say. And one more comment. In your proposed randomized trial, going up to 60 gray, I mean,
well,
isn't it a bit too high for that particular area? And what about late effects?
Well, I didn't design that trial, okay? And to me it's very similar. Earlier on we were talking about rectal cancer. And, in the watch and wait, the 50.4 gray is the evidence base that we have with long-term effects and long-term functional results. And so when Habra gamma escalates to 54 Gray and does not find any more patients sparing this, having sort of organ sparing from that, it's not surprising because you're treating the primary tumour to a higher dose. You'll get more complete responses in the primary tumour, but if you're not treating the lymph nodes to that sort of dose, and the bigger the volume you're going to treat, the worse your function is going to be as well. So I'm not sure that these, we don't have any functional data for 54 Gray and a watch and wait. So I agree, 60 Gray to me is going to be too high a dose, but I didn't design the trial.
So I think we should continue with the next presentation regarding how we should follow these patients up and also what to do with the management of metastatic disease.
Okay, well I'm aware you're probably wanting your lunch, so I'll be a bit quicker if I can. So, follow-up. There's a microphone. So again, predominantly local regional disease unless you don't control the primary or unless it recurs in a future date. So data from Act 2 suggests that isolated metastases are rare, making up only about 5% of the cases. So most of the metastases occur because you fail locally or you don't control things locally. And when we look at this, this is the progression-free survival, and don't forget that the progression-free survival was defined as any recurrence, local, regional or distant, and also death due to any cause. But actually, this is pretty flat from about here. And we have very, very few recurrences after 3 years. Okay? So what we did was we looked at the timing of salvage surgery in the anal cancer trial, and we looked at 4 time periods, getting them into more or less an even number. So those patients who were operated on up to 6 months, between 6 and 12 months, 12 and 24 months, and more than 24 months. And the interesting thing that surprised me entirely is, if you look at those patients who were salvaged early, their median overall survival was only 9.6 months. And this is probably because we mandated you to watch. So the patients there are really resistant tumours. They are the really nasty resistant ones. And if you go back to Nigro's original data, with those patients who did not respond developed metastatic disease very rapidly. So if you take the really resistant ones, they do very badly. I think one of the things that is common in the literature is these patients do better from salvage surgery in 6 months, but that's because these patients were probably programmed already to have a complete response and were operated on too early. If you look at the curves there, the impact of timing from salvage surgery until death, you can see those patients who were operated early have a pretty grim survival. But I mean, probably that would be quite good for pancreatic cancer, so I think you still do it, but it's just a bit concerning. So, and as I said, if you look at some of the other salvage surgery rates, including the Manchester series, there's a suggestion that half your patients are going to be salvaged. But I think that the longer you wait and the later your recurrences are, probably the better your outcomes are going to be. And I'm not sure that really intensive surveillance in those first 6 months is going to be that helpful. So there's no standard follow-up. Paris, and amongst other authors, looked at discrepancies between our ESMO guidelines and the NCCN, and one of their comments was the follow-up regime is marginally different. So this is the American guidelines, which do not use MRI. It's just DRE, anoscopy, and chest abdo-pelvic CT annually for 3 years. And they do a lot of DREs every 3 to 6 months, and a palpation of the inguinal nodes. So the ESMO guidelines are different in that we evaluate every 3 to 6 months for a period of 2 years, because most of your recurrences are going to be within the first 2 years, the vast majority, 6 to 12 monthly up until 5 years. Anoscopy is an additional option, but it's sometimes poorly tolerated, and I think, again, as is, you can, I haven't yet found an anal canal that's longer than my finger. It's not unlike rectal cancer, but I haven't yet found an anal canal that's longer than my finger. So Some people do recommend MRI on a 6 monthly basis for 3 years, particularly for T3-4, and I'll give you what my policy is. But suspicious progressing, so if the trajectory is bad, then probably you should biopsy these. Regular CT scans we did not recommend because there's no evidence, as in colorectal cancer, that you can salvage these things. Although I think there are patients where you can sometimes salvage isolated oligometastases. But as I said, data suggests that very few, perhaps only 1% of local relapses occur after about 3 years. So I can't see that maintaining your local surveillance really intensively after that time is going to be helpful. So my policy is I do an MRI, examine the patient at about 6 weeks. If all's fine and the trajectory is good, we do an MRI at 3 months. If this is clear, I don't do any more MRIs for T1, T2s. I just do a DRE thereafter. If the MRI is not clear, I repeat that until it becomes clear. But for the high risk, large T3, T4s, I often repeat the MRI at 12 months and at 24 months, but not after that. If the trajectory is going the wrong way, then I'll give the surgeon a ring and send the patient back to the surgeon to have a look and see what they think. And I ask the surgeon to biopsy when I'm sure there's residual tumour, but not until I'm fairly sure and they're on the wrong trajectory. I think there is a role for PET, but I'm not sure how to interpret. You start off with a PET of 12 and it goes down to 2.5. So am I going to say, right, we're going to biopsy, or we're going to operate? I don't know how to interpret that. So, just going on briefly to metastatic disease, about 10% of patients will develop metastatic disease. Bone, liver, lung, and periaortic nodes are quite common. Little published data, no standard regimens. Okay? So, the data in the US suggests that you can expect a 5-year survival of 31%. Well, I have no idea what they're doing to get 1/3 of the patients with metastatic disease alive at 5 years. Because certainly that's not our experience. In our experience, probably about 10% survive 2 years. So, I think one of the essential things is you need to get the patient back to the multidisciplinary meeting. Because if there are only a few metastases, sometimes you can surgically resect these. Sometimes you can surgically resect lymph nodes, periaortic nodes. Sometimes there are small liver metastases, lung metastases. You can do cyberknife. And sometimes you can re-irradiate as well. I do not believe that chemoradiation is like Catholic marriage. I think you can do it more than once. So, palliative chemotherapy in the ESMO guidelines, we didn't have any standard. We said that 5-FU cisplatin was often given, and we just commented that the responses are not very common. There are a lot of other drugs that have been used and are espoused by various people. The NCCN guidelines recommend either carboplatin and paclitaxel or 5-FU cisplatin, and they also have an option to go on to nivolumab or pembro. So we did, through the International Rare Cancers Initiative, we did a trial, an international trial, Interact, which was a randomized phase 2, and we randomized between what was probably the international standard of 5-FU cisplatin versus carboplatin paclitaxel. And we managed to recruit about 90 patients, most of them in the UK, but also some in the US and Norway. Marianne Guren's a fantastic recruiter in Norway, and some in Australia. And that's, I don't have any results, but the trial has been fully recruited and probably in ASCO it'll be presented. Some very nice French data using docetaxel, cisplatin and 5-FU, which is, it's a very effective regimen, but it's a pretty toxic regimen. I don't know if any of the medical oncologists have used this, but it's certainly a pretty toxic regimen. There's a standard DCF of docetaxel 75 mg and a modified DCF for patients who are a bit older or have a less good performance status. But the results are pretty spectacular from that particular trial. Objective response rate almost 90%, and just over 1/3 complete clinical responses. And some of those are really sustained for at least a year. So I think that is an interesting regimen and probably should be explored a bit more as well. There's a certain rationale for the checkpoint inhibitors because of the HPV, because the tumour is theoretically going to be more antigenic. because of E6, E7. And we know that there are immune markers that we can look at in some patients. Some patients will have high expression of CD8, PD1, PD-L1, and they are probably good candidates for checkpoint inhibition. So the background to anti-PD1 is Pembro with single agents of activity in the metastatic setting, response rates of about 20%, and nivolumab about the same. So there's this particular paper, and also the Morris paper, nivolumab for previously treated unresectable metastatic anal cancer. And what that shows is, again, I think I showed you this in the previous one, with a response rate of 9 out of 37 and 2 complete responses. So again, progression-free survival, not very good. Really, the overall survival is not too bad, but I don't think it's the answer. There are probably going to be other checkpoint inhibitors or other ways of actually utilizing nivolumab or Pembro. So we have a potential randomized phase 2, phase 3 trial that will be ongoing on the winner of the Interact 1 trial, and we'll put that into a setting where we will have maintenance nivolumab in one arm and nivolumab going forward. So that I think is the plan for the next particular trial. There are also some other funny things with immunotherapy. There's a listeria monocytogenes vaccine, which makes the immune system recognize HPV 7 expressing cancer cells, and that looks quite interesting on its own, although only one patient had a durable partial response. It's been used with radiotherapy, and I think there is a bit of mileage there as well. So I think the immune system is going to be exploited a lot more in anal cancer in the future. So thank you very much.
Thank you again for the most informative presentation. Are there any questions, comments? Can I just ask you, is there any role for using tumor markers, CEA or SCC, in follow-up these patients and avoid probably doing MRIs, which are more expensive?
Well, we used to use squamous cell carcinoma antigen quite a lot. I personally found it a lot more helpful in the past. If you get a high initial squamous cell carcinoma antigen, you're kind of looking for lymph nodes because it's a lymph node marker. We did it as a follow-up, but the only patient I think benefited in about 8 years was a chap who developed a second primary squamous cell carcinoma of his lung. And so we actually scanned him and we took that out, and it was a separate primary. They're completely different biological. So he was the only person that benefited. So I don't think squamous cell carcinoma antigen is going to be very helpful in the follow-up now.
I mean, the question of metastatic disease on the liver, you say that there may be some role for small metastases in the liver. And I want to add a bit of personal experience. We have had a small quantities, a small series of metastatic liver disease that we treated surgically after chemotherapy. And the results, I must say, this is a word of caution because the results were very good. We were very bad, excuse me, because we were able to resect and to have a free margin of resection, but still the patient recovered after a few months. So I don't think it's the right strategy in this kind of patient.
Well, the original NIGRA paper with 3 patients, he gave chemoradiotherapy to the liver. And certainly on 2 occasions I have given chemoradiotherapy to, say, about half the right lobe for a number of... And I had one patient, I mean it's all anecdotal, but I certainly have one patient who seems to have been cured and another patient that had a disease-free interval of about 3 years and then developed lung mets. So it may be worth it.
Thank you very much.